So everybody has said something, so I also have to say thank you for the words of Dustin, but you are in what we consider a house. So that's why a welcome for you is a welcome for a house that is working to make everything better, and the team is also the whole team that is working in Vilex and making from this experience something new and with a lot of challenges. So we were talking in a table last night about one word that you will see that we repeat in all our lectures, and one is about evolution. But evolution cannot be achieved without observation, and also with an open mind philosophy, because then we are not able to transform this observation into new acquisitions for making something improvement. This is what we know about the difficulties that we have learned in the last years, that means to stabilize the peritalar joints. And this has changed a lot of our concepts, not only talking about prosthesis or not, but talking about the whole reconstruction and the whole pathology that we are looking in foot and in ankle. It means talking about this wonderful, beautiful vedette bone that is the talus. Because this bone that is like a sandwich, the action of this makes a lot of movements, but has a lot of relationship with many other joints that make important to understand in order to make a good reconstruction. So this is one of the main important things that we have to keep on in our learning process with prosthesis, is to learn about the observation in different plane, and especially the talus in coronal plane. But when we go and make prosthesis, it's easy to make probably in a normal joint. The shape of a normal joint we learn, and it can be a mechanical thing to make this cut, this, we put, and it's all. But that is not reality. We know that reality is this. That is not only that the burn off of the cartilage, the bone is gone, but we see a lot of more pathologies in this joint. Reality is this. And most of our cases comes from traumas, or probably also from revision surgeries that make it even more challenging. This is reality. Or maybe this. What about this one? And what about this? Or even this? So we are here to learn that we are facing a long-term pathology that needs a solution not only by an implant, but need a solution by the understanding of the pathology and the biomechanic of all this deformation. In order to do that, we are just learning one of the tools that will help us to make a hindfoot reconstruction and also to give a better life to the patient, but that come into a success only if we understand that this is what we are going to deal with. This is the reality that needs a prosthesis. And we see that many of them were treated in a wrong way previously, and we have to solve that at the end. So that put us into the evolution of what Professor Hintermann has created, and talking about a three-component ankle. The wonderful thing of this is when you talk about the two metallic parts, components, and working with an insert that takes the position, it is magic, because you allowed this insert to take the position depending on the anatomy of the patient. So we don't change it. But over the years of observation and evaluation, we also realized that this wonderful solution has determining factors. Depends on the status of the ligaments, like the medial side, the deltoids, and all the function of the soft tissues. So it is important to go through this concept. We have learned also about the sagittal plane alignment. We have published these about the different positions. We were talking about anterior, medial, posterior. These are the different positions that the talus can have. And over the years, we see that we find these different concepts that makes also a challenge for us. And it is summarized in this example. We can see different patients over 10 years. All are success, forgettable about the symptoms and everything, but no one is identical like the other ones. So we are talking about different ankles, different patients, different situations, and all are happy. But it is because it was adapted. Or the opposite, when we see one patient with the evolution over 15 years, that is wonderful to have this data since the beginning of his career, no? So this patient has the evolution here, and what we see, is it changed? No, it kept the position over the years. So once it's adapted and it gets in the position, it keeps this. And we can see that also in the sagittal and lateral views. So this is the important thing, is to know that the insert over the years is not going to change the position. There is not going to be a motion at the secondary interface in the sagittal place, as we can see here, even in the contrast medium. So all these things can help us to understand more why it was working, and it works perfect. So this is the solution, and the success belongs because it is the adding of a second interface. And as we said before, the advantage is that it accommodates the prosthesis to reduce the shear forces. But over the years, the evolution concluding this, that maybe there are some disadvantages. And it is because it relies for the stability of soft tissues and may overload the soft tissues. So we need to look more for the intact syndesmotic and deltoid ligament structures. So we need to understand more about the real biomechanic and the forces of the soft tissues. And there it comes that it is an excellent result. As we see here, you will see that it is perfectly, and but the evolution of the prosthesis doesn't finish in the moment of the surgery. It takes a time of evolution. We have to look how it was going at the beginning and how it goes afterwards. So it is a proven work. It's a solution, it's a method for the treatment of the end stage. This is true. And it has evidence, a very satisfactory long-term implant survival with an acceptable revision rate. The main limitation is the coronal plane instability. And we come to this to see that even in the literature, we can see there is a problem with the rotation. Even the most expert surgeons are not able to 100% dominate the evolution of this rotational problem. We cannot predict it. And proof of that is these curves that we got for our studies and statistics. So this is also seen when we were trying to make this and confrontation in the OP, and see that we see the same results. And all the people here that are making prosthesis, you know that this is one of our big issues. So this comes to a new idea. We're not going to talk deeply about that, but all these lead us to look for another solution. So we need to adapt the prosthesis to the ankle of the patient. We don't need a prosthesis, we don't need the ankle to be adapted to the prosthesis. So this is a concept, and so we were thinking about that combines an advantages of the semi-constrained and mobile bearing ankle replacements. It means that intraoperatively we are doing the whole system as we learned before, but intraoperatively we see how our inlay position accommodates to the anatomy of the patient. And then we know that we are not forcing this. It is the adaptation of the prosthesis to the anatomy, and when it is done, we can fix it. We only do the fixation when it is turned into the right position. And as you see here, the evolution is the same, the technique is the same as we learned before. We see here also the controlling of the rotational, as we said before, and all this allowed us to say that this is a new concept, a new game change. because this is a customized ankle based on proven technology, respects the mechanical changes due to the osteoarthritis, and like a 3-component provides an alignment due to the anatomy, and then we give this stability, turning into a 2-component ankle, not changing anything from the normal axis of the patient, just adapting to this, so we are not forcing anything in this case. As you see here, once we make the insert in position and we see how it is stable enough, doesn't move, we don't have any gap, then what we go is to fix it. This is the moment that we are sure that we are allowing the prosthesis to adapt to the anatomy of the patient, and we are sure that it will work because there is no change forced. So in conclusion, for these two, the H2 design, a novel concept for failed ankles, all these are making us think that this is a new possibility, a new tool that we have in the whole budget of solutions for the ankle. Thank you.